We are your hosts, Nicki Shorr and Jessie Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ACHIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Hi, Nicki.
Hey, Jess, how are you?
Great, as always. It's wonderful to hear your voice.
And you as well.
So I have a joke, of course.
Yeah.
Why were the ants unaffected by the COVID virus?
I don't know. Why?
Because they have little antibodies.
It's cute. Funny as always.
Well, I try. So we have another really interesting topic for discussion today. I think we can all agree that communication is important in many aspects of our lives, but one could argue that it's absolutely critical in healthcare. So today we have Ann Scheck McAlearney with us to talk about her research article, Identifying Management Practices for Promoting Infection Prevention, Perspectives on Strategic Communication. So Ann Scheck McAlearney is an Associate Dean for Health Services Research, Distinguished Professor of Family and Community Medicine, and Executive Director of Catalyst, the Center for Advancement of Team Science, Analytics, and Systems Thinking in Health Services and Implementation Science Research in the College of Medicine at the Ohio State University. She also holds appointments in the College of Public Health and the Departments of Biomedical Informatics and Pediatrics at COM and at OSU. She has over 30 years of health services research experience, during which she has been actively involved in both performing research and disseminating research results to academic and practitioner audiences. Dr. McAlearney is internationally known for her expertise in both qualitative and mixed methods analysis and has been continuously funded for over 20 years. She has authored over 300 peer-reviewed publications, 11 books, edited books, and more than 100 book chapters. Dr. McAlearney has served as a grant reviewer for 18 years, including for the Agency for Healthcare Research and Quality, National Institutes of Health, Patient-Centered Outcomes Research Institute, and the National Science Foundation. She currently leads a major research project focused on applying management practices to prevent transmission of healthcare-associated infections, as well as co-leading the NIH-funded Center to Stop COVID at OSU. Her additional ongoing research focuses on addressing care disparities, information technology innovations in healthcare, population health management, quality improvement, and organizational development. And Dr. McAlearney received her undergraduate and graduate degrees from Stanford University and Harvard University's T.H. Chan School of Public Health. So,
well, that's a very learned lady, Dr. McAlearney.
Absolutely. So we're super glad to have you here with us today. Can you kick us off by telling us what prompted this research?
Absolutely. So thank you very much for inviting me to participate. This is a delight for me to get to discuss this research. This project came about because my background is as a management and organization scholar. And when I looked at the issue of patient safety and in healthcare-associated infection prevention in particular, what I saw was there is a tremendous amount of information and evidence about clinical practices that can be used to reduce and prevent healthcare-associated infections. Yet not everybody was doing those clinical practices all the time. And it wasn't because people didn't want to do the right thing. It just seemed to be because often it was difficult to do the right thing. So my research questions started from a management perspective to say, are there management practices that should be put in place or could be put in place to support the accomplishment of the clinical practices in a more rigorous way so that people were able to do the right thing with respect to infection prevention 100% of the time or just more of the time. This originally came from the notion that if you did perform 100% of the time looking at the reduction of central line associated bloodstream infections, it was possible to get to zero infections in hospitals. And in the beginning of this endeavor, many people did not believe it was possible to get to zero infections. And there was an assumption across the board that some level of infection was just inevitable because people were sick, because bugs are flying around, et cetera, et cetera. And yet early research on the clinical side proved that if you put these clinical bundles into place, you could in fact get to zero CLABSIs. At the same time, it was proved very difficult to sustain that number zero. And so my research was framed around how hospitals that had done a good job of preventing healthcare-associated infections had done that from a management perspective and what kinds of things they had found important to support the consistent application of clinical best practices. So that's really where this came about.
That's fantastic. And I would say that that's still something that infection preventionists struggle with today, is that concept that patients are sick and you can't get to zero, it's impossible. So that's definitely something interesting to hear coming out of this research as a prompt.
Yeah, I agree.
So do you know if, as part of these communication processes, any apparent cause analyses were performed for the hospital-acquired infection cases at any of these institutions as a method for determining whether there were education or practice gaps to then focus on those areas to review with staff?
Yes, absolutely. So across the board, we found that, again, people were really trying to do the right thing. So whether it was called a root cause analysis or a deep dive or, whatever these reviews were called, they were being performed. And what we also found was a lot of variability in terms of who was leading these investigations, how frequently they occurred, and that kind of thing. So we were trying to disentangle what was it about the process that could be standardized in a way that could help the hospital with infection prevention in these areas.
So were there any differences in what categories or content that the executive leaders and mid-level leaders placed importance on?
Yes, and I would say in general, this is true across different hospitals. And for this particular study, we visited 18 different hospitals, so we got a pretty diverse group of places. And to explain a little bit more about this diversity, some hospitals are standalone safety net hospitals. Some hospitals are part of health systems. In a health system, we might conduct interviews at two different hospitals, one may be a community-based hospital, one might be the teaching hospital, flagship hospital, and that kind of thing. So we were able to interview executive leaders in health systems, hospitals, and so forth. So the range of perspectives we got was very, very broad. What I would say is that across the board, the concerns of the executive leaders and the messaging of the executive leaders was related to the urgency with which the hospital really perceived infection prevention. So as a particular example, where one hospital had as their chief executive an infectious disease physician, infection prevention was very high priority for that institution, not surprisingly.
Very.
Whereas in other hospitals where that might be more of a management type hospital administrator, they were learning from their clinical leaders and administrative leaders and kind of the mid-level about what this really meant. And so one of the things that was very telling early on was whether or not infection prevention and infection rates were communicated across the board, broadly to the hospital board. Were they public? Were they shared in spaces where patients could see? Or was this something that was more under wraps? And looking at places that had more public presentation of infection data, there was a higher priority, and also the executives in those institutions where infection prevention information was more broadly spread were more cognizant of this as a priority for patient safety. One hospital I visited as part of an earlier, so in addition to the 18 hospitals I visited for this study, I was part of an earlier study where we visited another 9 hospitals. And one of those early hospitals we visited, the infection rate had basically made the front page of the local newspaper because people were effectively dying. And that attention brought to infection prevention in that hospital got the attention of the governor, who called the CEO. And all of a sudden, infection prevention became very important. On the flip side of that, once COVID hit, infection prevention pivoted towards thinking about airborne agents with COVID-19, and people worried about that. And we've seen some slipping of traditional infection prevention efforts as most hospitals that we visited had to pivot. I'd say all hospitals had to pivot to really focus on COVID-19. And that has seen a resurgence of certain hospital-associated infections because of that lack of attention. And again, a lot of this has to do with attention. So when you go to a hospital where executive leadership pays attention to this, it is more likely that you are going to have better luck and better experience in terms of having infection prevention success.
Yeah, that's, I feel like you're preaching to the choir here because I think both Nicki and I have faced issues with both the focus on infection prevention being a priority, but also with all of the issues around COVID that took that focus away. So we understand the importance, and I think it's great when we have leaders that understand the importance as well. And one of the questions that came to mind for me when I was reading through the article was there was mention of leaders supporting public-facing communications related to hospital-acquired infections. And although, no institution wants the public-facing communication to be that patients are dying, but are there leaders that support this communication in other ways to help raise awareness from what you saw in those other institutions?
I would say that definitely the public-facing information is important. But I think another really important component of infection prevention success is putting the means to succeed in the hands of the leaders that can drive that success. So this study was a large qualitative study, which meant that we physically went to these hospitals until COVID came and we couldn't visit anywhere. We physically went to the hospitals and interviewed in person literally hundreds of people across these different hospitals. And that's why the distinction between the executive level leaders and the middle level leaders. Because what you're doing in a qualitative study like this is that you're interviewing and you're using their words as your data to tell a story. So when you have the perspective of middle level leaders, you get a lot more granularity in terms of the things that they're actually doing. So for instance, one middle level leader at a hospital talked about success and said, I think at the onset of when we first had our nice reduction in CLABSIs, we used a summit it was multidisciplinary. So you had everybody gathered around to discuss what are the barriers that keep us from doing this or that. And another middle level leader explained the usefulness of sharing lessons learned from recent HAIs. That summit in that particular instance, being multidisciplinary, is another key success factor in terms of infection prevention. So you have all sorts of individuals gather around a table, gather around a wall, wherever it is, discussing kind of what went wrong and what could be done differently to avoid this problem in the future. And that's where you go back to, your first question about root cause analysis. How did this happen and what can we do to prevent it from happening in the future? Lessons learned. I think one thing that was interesting in terms of conducting interviews in health systems versus standalone hospitals is that some of the health systems could learn from the hospitals within their system. So they would learn that, Hospital X was doing well at CLABSI prevention. Hospital Y was doing less well. Well, let's have Hospital X's infection preventionists talk to Hospital Y's infection preventionists and learn from each other about these best practices within the same hospital system and environment. Another thing that we found was that sometimes the smaller hospitals that were more family-centric in the sense that the employees were there for a long time, everybody kind of knew each other, they were able to have a culture that was very promoting of patient safety and infection prevention because there was so much collective accountability. Again, everybody knew each other. They'd been employees for a long time, as opposed to some of the larger hospitals and maybe some of the teaching hospitals where there's a great rotation of staff, changing of staff. There's traveling nurses, there's residents that rotate and that kind of thing. So each new group of people has to learn the way things are done, which creates the need to have ongoing training in a way that might be different for a hospital with a more stable employee population and a smaller employee population. That's
amazing. That's exactly the kind of culture that our hospital system is trying to currently cultivate with the infection preventionists, is utilizing each other as resources. So I love that.
Yeah. And a lot of this talks about how communication drives infection prevention and the programs. And I'd like to ask a little bit about the multidisciplinary meetings that you talked about, because it also relates to, what you talked about earlier with the RCAs and the deep dives. And there's a lot of variability in who led them. So can you give us a little insight on who led a lot of those meetings? I'm trying to get an idea of, did who the leader was make a difference? Was, if it was led by infection prevention or quality or nursing leaders? And this is kind of a multifold question, but did you notice that certain hospitals that placed emphasis on infection prevention had infection prevention as leaders, or did they allow other people to take the reins? I'm wondering how that looked.
So I would say in a word, variability. It really varies in terms of the different places. So, say I've visited 25 hospitals in the past, several years, not the last two, of course, but across these hospitals, it really varies in terms of who is making the pitch, who people listen to, and so forth. So I would really say it can be anyone. Hospitals that really had a strong presence with infection preventionists were hospitals where the infection preventionists were known by name on certain units. So it'd be, hey, Nicki, good to see you today. Why are you up here? That kind of a thing.
Yes, the why are you up here question we get a lot.
Yeah, I'm sure, right?
Some scrambling.
Yeah. Right. But I think that, there was no right way. There was no single right way to do it because it depended so much on people's perspectives, enthusiasm, even personality. Is this a person that's really going to drive change? I will say that the places that had designated somebody as an infection prevention champion, whether that was an infection preventionist or a nurse leader or unit leader or whatever it was, the champion role is definitely one that is successfully leveraged in infection prevention, because you do have more of a sense of somebody's paying attention, you know who that somebody is paying attention, and that kind of thing. But the other reason there's such variability across hospitals is because there's such variability within hospitals. And one culture is not the same culture across the hospital. The NICU has a different culture than the other ICU, and the ICU has a different culture than the med surg floor. And there's different staffing ratios and different presence of physicians, and all that variability plays out in terms of the variability within a hospital. And I think one of the things that's very hard to disentangle when you're looking at infection prevention and you're looking at things like patient safety scores is that trying to put a single number on a hospital is complicated when you have so many varied things happening. If you have a big academic medical center and you get transfers in from other community hospitals and so forth, we heard a lot about people complaining that this isn't really Mike Labsy, he came in with this or whatever it was, but it's still counted at that hospital. So I think that the way that a lot of the data are aggregated makes it hard to disentangle. And that's one of the reasons why we did this deep dive into certain hospitals and certain units to figure out, is there something we can learn? And I think one of the things we learned is it doesn't matter who is paying attention in terms of the role. It matters that someone is paying attention in terms of infection prevention and keeping their eye on the ball and not letting things slide and that kind of thing. I think that is probably the most impactful way to kind of describe the fact that there is no one size fits all answer.
Yeah, there's so many variabilities in hospital, especially with leadership and, like you said, size of the hospital and cultures that, I guess you can't really pin it down. But again, like you said, good to make sure that somebody has their eye on the ball.
Yeah. And I mean, I was just going to say, and, the fact that everybody is part of that infection prevention team, I think it speaks to that as well, where we all play a part, everybody that comes in contact with patients while they're in the facility or, participates in the care. And I had noted in the article as well, discussions about the safety stories that illustrated how everyone working within the facility was part of that team, and was curious about whether leaders talk about including non-clinical roles like our environmental services staff in those communications to not only raise awareness about infection prevention, but also to ensure that they're aware that they are participants and part of that infection prevention team, and they're very important.
Absolutely. And I would say that the example of environmental services staff, I have a story that was very compelling where in a hospital that included that role in these safety huddles and so forth, and in this sense of we're all in this together for infection prevention. The story was that this individual, kind of was participating, and the issue was that there was a spread of a particular bug across rooms. And the environmental services person says, well, I use the same mop when I go from room to room. Do you think that could be part of the problem? And it was this aha moment for that particular unit. Like, yeah, that's probably a big factor we should pay attention to. How do the cleaning supplies get transferred if we're really bringing infections from one place to another? So I would say that the use of an inclusive view of infection prevention, that we all can do our parts, is very, very important. And I also would say that with the COVID-19 pandemic, the importance of hand washing became really, really clear. And I think getting patients and visitors involved in infection prevention has taken on a whole new centerpiece with COVID-19 and how people had to be so vigilant. I think that's an opportunity that we can pursue going forward, just with that heightened awareness.
So what were some of the barriers that the leaders identified?
A lot of barriers that probably won't go away anytime soon, but staffing is a big problem. Just time. These individuals are working so hard, so many hours, and have so many different priorities. So if you think about infection prevention is one of 8,000 other things that the bedside nurse has to be.
Right. It's getting wrapped up with everything else, basically.
Yeah. And I think that's it. So it's competing priorities is a big barrier. And again, that's not going to go away.
Right. It gets diluted in the mix.
And the staffing challenges, I would say that the places that had more traveling nurses, that's really a problem because they are trained differently. They don't understand the culture of the unit. It makes the unit culture change on a daily, shiftly basis. So I think that can be a big barrier just in terms of, what's going on in that marketplace that's leading to staffing shortages, which of course, pretty much all hospitals are suffering from now. I think there's also some structural barriers, physical barriers, in the sense that, I've visited hospitals where there'd be one sink on a floor. And that is unfortunately a historical construction problem. But, especially I think after COVID, we know that we need more than one sink on a floor.
And I've never been to a hospital that did not perceive themselves to have some sort of structural problem. We don't have room for this. We don't have space for to put clean utility here and put, something else here. So space and configuration is always a problem. And probably because infection prevention may not have been at the table when it was being designed. I don't know.
Yeah. May not. Yeah, I think that is good insight. I mean, I think that some of the newer facilities, they've really thought these things through. But as you said, the space for, clean versus dirty, where do the hand sanitizer stations go? Is it inside the room? Is it outside the room? All that kind of issue around structural, physical design, environmental design has, I think, become more acute as well during COVID.
I think it makes sense to think about how we can make things easy for people to do the right thing, right? So having access, like you mentioned, to hand sanitizer, so that, they literally have to walk by it, when they're leaving a room in one way or another. So again, I love the storytelling. I think it's a fantastic way to generate an emotional response from the listener. And so was this something that leaders were using to communicate the safety stories? Because I feel like it can be such a powerful, impactful way to get people to think about their own practices and how they could be affecting patients. And then also, is celebrating the successes more effective than dwelling on the infections that occur?
Those are good questions. I mean, this storytelling as a part of strategic communications that support prevention of infections is very, very compelling. And I think there's different reasons that we found that hospitals were using storytelling. So as you noted, one big reason is to create impact and emotion. And so if you create an environment, so you have a public or even just an employee-wide or even a smaller forum, and you start that emphasis on patient safety, and whether or not you use an actual patient, I've seen places where they would bring a patient in to talk about a near miss or something like that. And there are also the stories where somebody, baby got a CLABSI and died, and, that creates tears and that kind of thing. So that impact and emotion is definitely there. With respect to celebrating success versus, less successful efforts. I don't think that there is a consensus about which is most important. I think if you're trying to avoid burnout, I would go for the acknowledging success, because I personally wouldn't want to dwell on the the losses. But I think in some places it was more of a wake up call to say, look, we've got to do better about this. And then the other reason that stories are shared in hospitals around infection prevention is to educate people about how things could be better. This story I relayed about the environmental services person that kind of figured out the source of this infection transmission was a story that was told. There's other stories about, how things kind of were missed and then somebody found them, and sharing those stories. It becomes part of kind of the lore of the institution when you have these good or less good outcomes that are shared. But I do think that the focus on good catches and safety, positive things like, shouting out individuals that did the right thing from a management standpoint, that is definitely my preference, is to dwell on the great catches and so forth. There was one place that we visited, and they had on the door of the nurse manager, they had a fishing net, and the fishing net was filled with different fish that then had little notes. That's cute. Yeah, super cute. Little notes about, the great catch that was identified with that fish that was in the net. And I thought that was really a great visual celebratory way to recognize good things.
Stealing. We're going to implement that at our hospital now. You mentioned bringing a patient in to tell their stories, and I was thinking about how our hospital system works. We have leaders from all across the nation, really, who participate in these shared learnings once, every so often. And we get stories there, but they don't necessarily get cascaded down. So give us some strategies on how to cascade some of those stories from leadership to staff. I've never thought about bringing a patient in to tell their story.
Yeah, I think that patient stories are very compelling. Obviously, you've got, the emotion, you've got the experience of being a patient and that kind of thing. And a number of places do emphasize that, whether it's, maybe it's just every once a year or something like that, or maybe it is every quarter or something. But I think that the patient stories are perhaps more tangible to the participants and maybe more likely to be cascaded in terms of the messaging. I think that the role of kind of greater involvement of all sorts of people in all sorts of different opportunities to communicate about patient safety and infection prevention is incredibly important, so that you might have this, all leadership meeting that happens every 6 months or something, and that experience is lost on the rest of the organization. But some places deliberately figure out what are the talking points to cascade through the organization, through the various communication modules that the institution might have. So maybe there's a newsletter or a homepage that flashes up stories or something like that. So some places have successfully made this deliberate in terms of the cascading and made it an expectation that say a place has daily huddles, or say they have multidisciplinary rounds, or say they have something like that. If you get that infection preventionist as part of those events on a regular, semi-regular basis, then that also creates an opportunity for that person to represent what it is, the voice of the patient, the voice of the staff member who did a near miss, that kind of thing. And I think that inclusiveness is very important.
We always do a scorecard for the nurses that we post quarterly. So it's got, what our CLABC or CAUTI or C. diff rate is, and patient satisfaction, et cetera, et cetera. But I do want to go back to that patient story. So you said there was a hospital that brought a patient in to tell their story. Do you know what the details were? I know you probably can't give a whole lot of details, but What was the story? Did the patient come talk to the staff meeting? I'm really curious about this.
So I've heard of many different ways that this is done. I will not be able to relate the content of the story, but one was they had I think a biannual kind of all hands meeting, and were able to bring in, they would kind of collect these stories and then have, and it wouldn't necessarily be one patient, it might be 3 patients that came to present to this all hands meeting. I've heard patient stories being relayed to a hospital board. That's also very compelling in terms of trying to promote the importance of infection prevention. Some stories that have been shared are sad. Some family members will come and talk about their loved one who died because of an infection. And I've seen that done at a local level and a broader level. And I think one of the things that researchers are doing now more broadly is including the patient voice in how we study things that affect patients. So learning from patients, the things that are important, that kind of thing. So anything to flesh out those report cards. So yeah, your CAUTI rates and your CLABSI rates and your patient satisfaction scores and that kind of thing. But any way to personalize what those rates mean and how you can make a difference and what you do does make a difference with respect to patient safety and impact is something that will resonate with most humans longer than knowing your CLABSI rate is, X. Another thing that's interesting, though, about those report cards and the scorecards is that what we found is that the way you present the data is also very important. So that we have found that it's more impactful to the observer of the data to learn that it's been a number of days, 100 days without an infection, rather than your rate is X. People just don't think in rates. But what happens when you promote the number of days without this infection, that infection, so forth and so on, there becomes a collective effort to not break the streak.
Sure. Yeah, we do that as well. We every morning say our last CLABSI was this date, and that's basically what the scorecards say is how many did we have last quarter or whatnot. So we do a little combination of that. But you're giving me a lot of material to move forward and kind of. You're giving us a lot of information. This is great talk.
Well, and the other thing about this research study is that one of the products, in addition to a number of papers that apparently at least you guys read, yay, papers that get published in different academic journals and practitioner journals, is that we have developed basically a website that has a toolkit that will provide guidance around infection prevention and management practices in infection prevention. And that site is not live yet, but it will be going live, I've been told, within a month. And the idea behind this toolkit is that it will be publicly available for anybody to look at and have downloadable PowerPoints and training modules. So you say you want to do something like tiered huddles in your institution and you have no idea what that means. So there'll be explanations and like I said, there'll be PowerPoints. We've pitched things to different audiences. So this might be the message that you're sending to your leadership, and this might be the message you're sending to frontline staff. And those messages might be phrased slightly differently in terms of the level of the audience and the level of detail that they need to learn. So we're hopeful that once that launches, it will be broadly disseminated through the funding agency for this work, which is the Agency for Healthcare Research and Quality. So one of the federal agencies. And it's hoped that we can promote that as a way for hospitals really to help themselves.
That's fantastic. I mean, I know that we have a lot of Lone Ranger infection preventionists out there who could use these materials and take advantage of understanding how to communicate differently with both the leadership and nursing and various groups out there. So I think that's something that could definitely be very widely used and very advantageous to all of us out here. And also, I love what you were just talking about the using the numbers of harms rather than rates. I think a lot of times we talk about this, about how, a rate doesn't necessarily translate the same way. And one of the things that we had seen in the past was actually using like little people on the charts instead of, just bars or dots, because you're actually like, that's 3 people or that's 5 people that experienced a harm. So that's all amazing and fantastic. I'm very excited. So the last question that I had is, so based on what you heard and what you observed, was there one form of communication or route of communication that seemed to be more effective than others, or did it depend entirely on like where the communication was, the type of facility, the department, that sort of thing?
I'd say it really depended. Again, a lot of these things have to do with the hospital size, whether it's a system or not, what's really built into the communication structure of that hospital. So, if there's a newsletter, do people read it? If there's emails, do people read them? I would say that face-to-face communication, to the extent that you can emphasize the priority on infection prevention, is going to be more compelling. And when you mention, the having the people on the scorecard to represent people, I think anytime you can personalize any of this, it makes it more understandable and relatable to the individual that's getting that message. So an example that I also saw was one place when they were going for days without infections. They took, and it was just one unit, and they took pictures of the unit staff members with a number. So, Sally was number 1 and Jessie was number 2 and so forth and so on. So if it was 12 days, or maybe it was by weeks, but, days or weeks without an infection, there'd be pictures up on the wall. It would be Sally next to Jessie because it had been 12 days since our last infection, kind of a thing. And I think that really, even though none of us really like our pictures, as shown by the fact that none of us are on camera right now, I think it really was impactful in creating a sense of teamness in terms of infection prevention for that unit. And I think that really resonated well. They were proud of it, even if they didn't like their picture
too.
Yeah, this has been a great discussion. Really, really appreciate having you on. What would be your biggest takeaways for our listeners today?
I would say that it really is a combination of strategies for infection prevention. It's about the people. So to the extent that it's about the patients you impact, but it's also about the people that are involved in preventing infections, and making it easy for those people to do the right thing for the people that they are serving is incredibly important. I think the opportunity to communicate constantly cannot be overemphasized enough. If you think back to the beginning of COVID, I don't know about your institution, but we had to figure out, look at that. People don't know how to don and doff their PPE. So let's do a video and let's do an educational thing. So it's trying to communicate, but also be aware of where there may be things, where there may be gaps because, so-and-so's new and they didn't get the training, or maybe they did a computer-based learning and guess what? They didn't pay attention. So they didn't really learn how to do this. So really kind of keeping the attention and focus on infection prevention in spite of everything, because it is, not only is your hospital going to get, it's expensive. We all know that, right? It's expensive and people die and hospitals get dinged for things like this. But that's the second part. The big part is that it's really important that hospitals are not a place where people get sicker. We need people to go to hospitals and get well and get out of there. So to the extent that can be a focus over time, I think it's a incredibly important.
Yeah, I absolutely agree. And I think one of the things I always think about is what if it were me, or what if it were a loved one, and, try to extend that thought out to, the people that are caring for the patients as well.
So yeah, and then there's one other story that I wanted to share that really emphasizes how important it is to recognize that people do want to do the right thing. We were visiting one hospital, and that hospital had a PICC line team that was responsible for PICC lines across the hospital, and yet their infection rates were not good. And in talking to these nurses about their experience, you could tell that they were visibly frustrated with these rates not going down, because they were really paying attention. And one of them basically turned to the other and said, "We just want to know what's going on. I mean, really, who's spitting on our lines and spreading these infections throughout the hospital?" And it just was such a great example of the fact that they really are trying their best. And yet sometimes it's just tough.
Yeah, that is. But thank you so much. This was such a wealth of information, and we look forward to hopefully seeing the toolkits in the future and having those available for everyone to use. But just phenomenal, and just thank you so much for joining us today.
We are Nicki Shorr and Jessie Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business. To hear other AJIC podcast episodes and to access information about this podcast in the field of infection prevention and control, go to our website at agicscienceintopractice.org. That's AGIC, scienceintopractice.org.
AJIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology, with input from the APIC Research Committee and Pat Stone and Jean Brandt at AJIC, and APIC staff Lisa Tomlinson, Liz Garman, Bobby Gulshan, Chris Ruiz, Kelly Lynn Russell, Sylvia Quevedo, Kaylee Deaton, and Christine Miller. We work in partnership with Human Factor and audio tech Blake Alton.